So today we're just going to talk through the ventilator tubing and just the basic care of the patient, especially of the COVID-19 patients. So I'm just going to do a basic talk through. So this is the patient. These are the ET ties. It's just to make sure you can get 2 fingers in at all times, and just to make sure that the tubing isn't, that the ET ties aren't too tight on the patient, because obviously if the patient's coughing you don't want them to extubate by accident. Just to make sure you take note of the size of the ET. So this is size 8, just to have that documented at the start of your shift, and just to take notice as well of where it is at the lips. So you can see here the numbers. It says the size 8 tube, 28, 27, 26. And you can actually see here it's at 24 centimetres at the lips there, you can just about see. Just have that documented as well, that if that tube migrated or slipped, and if the patient desatted or stopped ventilating, that you'd be able to notice if the tube migrated or it has slipped down. So you have the ET tube, then you have a closed suction, which we'll be using for all COVID-19 patients. This is to be attached to your ET tubing. You'll next have just the catheter mount. Patients with COVID-19 are not for any inhalers or any nebulizers, so we'll be given inhalers in through here and through the concertina, which we'll demonstrate there later, and closing the cap off there again. I'll be using a HME, which is antibacterial and antiviral for all patients as well as COVID-19. And here there'll be a little connector here for your end-tidal CO2, which connects up to the monitor up here on the screen. So next is the dry circuit is recommended for all patients with COVID-19. So therefore there is no humidification, there's no heating wires attached to any of this. There's only the expiratory and the inspiratory limb here connected. There is a filter built into this ventilator, so therefore that dries it out itself, so there's no humidification attached to any of this ventilator circuit. Closed suction, we normally only put the closed suction on patients with people 8 and greater. However, we're going to be using it now on all patients with COVID-19. So the main purpose of this is so that we try to limit the amount of exposure we have at all times, especially in suctioning patients. So to use the suction, there is a cap here to open and close. So you can see this is closed off to the patient, so therefore I can't press to suction there. So with the port here, I'll be opening this up and connecting this on here to my suction. So it'll be my wall mounted suction, and the pressure is 150 to 180 millimetres of mercury, and that will be already set on the suction tubing over. So to suction the patient, I'll be holding tight onto the ventilator tubing, because obviously I don't want to expose myself at any times, so I'll always have my PPE equipment on, especially my mask, my gown, my goggles, gloves, and I'm just going to hold the tubing. So before I start, I'm just going to hit suction. So this gives the patient 100% oxygen for 2 minutes, and that will automatically turn off after the 2 minutes. So therefore the patient is pre-oxygenated before we suction them. So just the suction, I'll have a hold close tight here, and I'm just going to guide the suction tubing slowly down. So the suction tubing is measured according to the patient's ET tube, which will already be done by the ICU nurse. So to suction, I'll have to open up the clamp here, and I'm going to press and hold and slowly withdraw, and try to do that action within 20 seconds max. Perfect. So and I bring it the whole way back. So I can see that there's a little tip here, the black tip. I want to make sure that that black tip comes the whole way back the whole way out of the suction tubing there. So after suctioning, I'll close off the clamp. I'll disconnect the suction tubing, put the cap back on, and then I'll dip it into sterile water. So there'll be sterile water at every bedside. I'll dip it in just to clear the tubing of any phlegm that I've suctioned, or of any contents that have come back there. So for example, is my suction tubing, if this is all quite mucopurulent and purulent secretions, I want to try mind my suction tubing, because at the moment we change them every 72 hours. However, if stocks do get low, we won't have the necessary equipment to change these as often as required. So therefore we need to make sure that we mind the tubing to make sure that there's no secretions left in it. So to do that, I have a little port here, but there's a backflow valve in this, so therefore that won't leave any secretions and fly out and be a risk to any healthcare staff. So with the cap here, I can open it, and I'll get a pre-filled syringe. So the pre-filled syringe for polyflush, they're already just made of sodium chloride, 0.9%, and there's an expiry date on that as well there, 7/22. So I'll take off the cap, and I just have to hold it quite tightly there. So the aim would be just to flush out the suction tubing here. So I'll move this in just as far as the black cap here, so that I can see I only want to clear the suction tubing. I'll connect that back up to the wall mounted suction, just like so. I'll open the port back up. I'm just going to inject in 5 mils. So it should just be there at the tip of the tube, and I'm just going to suction that back then. And this will clear all the tubing here of any secretions, especially purulent secretions within the tube. So when that's done then, I'll just close off the cap and I can disconnect and put back my wall suction. So as we were saying, there's no nebulizers to go through, so we want to try to keep the circuit as dry as possible. So we have, if the patient is quite wheezy, this is your normal Ventolin inhaler that any patient would have, especially asthmatics. So this is just a placebo, but we're just going to say this is Ventolin and the patient is quite wheezy. So with this, we're just going to open the concertina, and we're just going to put in 2 puffs in there into the circuit and close it up again to try limit the amount of exposure we're getting and to try reduce the dead space at all times, because it is quite a long surface and there is quite a lot of dead space. So this is a HME, as I was saying. These need to be changed every 24 hours. So these are both HMEs that we'll be using. So for example, it's 24 hours later, or if this is quite water clogged, that's another indication for changing these, because these are only, there's a little bit of fibre through these, so they can clog up very easily, especially if patients are on high amounts of oxygen or high PEEP. So we just need to keep an eye on those, because obviously that can be an indication that patients can be desatting or dropping their tidal volumes. So we need to keep an eye at all times. So I'm just going to demonstrate there how to change these. So we'll be clamping the tube with a bit of gauze, as so, and to try prevent the exposure from the ventilator to us, we'll be hitting the main screen and hitting standby. Are you sure you want to stop the ventilator? Yes. So this is stopped now straight away. So therefore the patient has stopped ventilating, and as well he's unable to cough out because I've clamped his tube. So therefore I'm able to safely change over my HME and my end tidal safely without being exposed to any secretions from the patient. When that's done, I can unclamp and hit the word resume. So we'll try to do that as safely and as quickly as possible, because obviously we don't want to leave the patient without oxygen for too long. And as well, we don't want to be exposed either. So therefore we're not getting any coughing or any exposure from the patient, and as well then the ventilator has been stopped, so there shouldn't be any flow of any air or gas or any secretions back from the ventilator tubing either. So the end tidal, that will be changed also every 24 hours. It's connected up to the monitor, so we'll keep that facing upwards at all times, because we don't want any moisture to get into that tubing there. So just to keep it upright at all times. So this is actually quite heavy tubing, so we'll just make sure that it's always clamped onto the bed or onto a pillow, just with a red clamp there, so that's always protected as well at all times. So that's how to change the HME filter, and we've talked through suctioning, which we'll have clamped off there at all times as well, and we've talked through how to clean the suction there as well, and the suction tubing. So now just going to move on to arterial lines. So this is the patient's arterial line. It's a light green tubing there. It's like a cannula tubing, only it's quite longer. So this will be attached to the patient. Usually we do recommend that they are sutured in place. However, they won't always, depending on the needs of the doctors. Obviously they won't be able to suture them in on all patients that come in, especially if there's a high capacity coming in at any time. So there'll be a note on all arterial lines for taking blood samples only, just to remind people that they're not to be used for injecting. There's never to be anything injected into an arterial line at all times, just for safety, to let everyone know, especially junior staff. So this is what your arterial line will look like. It's going to be in a transducer bag, So it's going to be 500 mils of sodium chloride, and that's going to be attached onto the bag here, and that will be after being primed. So we need to make sure that this is pumped up to 300 millimeters of mercury at all times. So you can see there is 175, so it's at 300 millimeters of mercury there. Okay, so we'll close that off. So just make sure that that's always at 300 millimeters of mercury. So therefore that means this line is being transduced with 3 mils of saline an hour, just to keep the arterial line open, so it won't clog off. No clots will form there with blood. So I'm just going to show you how to take an arterial sample for bloods and for an arterial blood gas. So there's an off here. So I'm going to turn that off to the patient. I'm going to open this up here. So I'm going to use a Clinell wipe. So my PP on at all times. Just going to wipe. So I need to try clear this because, as I said, there's 3 mils of saline going in every hour. So I'm going to open this up. I'm going to draw back 1.5. So that will just make sure that there is blood starting to come into my syringe there, so I won't get a hemodiluted sample. I'm going to turn that off to the patient. I'm going to dispose this into a sharp spin. And this is what my arterial blood gas syringe will come in the packet like this. So I'm going to take off the cap and inject out all the air. So I'm going to attach this on here. So I'm going to turn this, open this up and turn it off to the transducer, and I'm going to pull back 1.5 mils of blood there now. So I'm going to turn it back off to the patient again, and I'll be handing that then to the ICU nurse full of blood. That'll do the ABG for me. So therefore there's blood here now after collecting, so I need to try clear that sample. So I'm going to connect that up here, and there's a little toddle. This will be connected here at the bedside like so. So at the bedside I'll be able to take this out, and I'll just pull this, so this will clear out any blood that's here in my circuit, and then I'll turn that off. So now I need to push back all the hemodiluted blood that's here. So I'm going to pull the toddle there, and that'll flush the line here, just to keep that patent so that won't clog off. So just there will be your tracing of your arterial line will be up in your monitor. So it'll be a lovely dichrotic notch, and it'll be a nice waveform. So if that flattens at any time, the things you'll be checking, make sure that your transducer bag is pumped up to 300 millimeters of mercury, because if that's not pumped up you won't get an adequate tracing on your monitor, it'll be quite flat. And also just make sure that your dressing is intact. So you can see here, this can kink very easily. So you can see here that can actually block off my tracing there as well. So I wouldn't get adequate tracing there of my blood pressure either. So just to keep an eye at all times, and just to check your dressing, especially if they're not sutured in. They'd be at risk of falling out, dislodging, and of kinking over there. So that's your arterial line. And so just at all times to make sure you're protecting yourself, and you have your PP on at all times. So if the patient disconnects, the first thing you're going to do is put on your PPE equipment. So try and make sure that you have your goggles, your mask, your gloves and your gown on at all times before you run in to reconnect the patient back onto the ventilator, because you need to protect yourself at all times to make sure that you limit the amount of exposure you're getting, because obviously you don't want to try to catch this virus, especially when you're caring for patients. Just to make sure, no matter what, that you always protect yourself before you connect up with the patient at any time. So they're the alarms that you hear. If it does disconnect, you can just keep alarming. So you'll hear those alarms there. It'll go off there now again. And you can see there's a straight line as well, because the patient is not ventilating at this time. So to connect up the patient then again, when you have your full PP on, connect up there now again. I'm just hitting alarm reset, just to reset everything. And you can see now the patient is back ventilating now again. And everything will settle down. The brawn pumps is what we use here. They're the brawn pumps. So So what we're saying to all staff is just to be aware of the infusions. So there is going to be, for example, noradrenaline, which is an inotrope, and if there's propofol as well, which is sedation. So what we're saying to staff is just to be aware. You can flip down the cover here, so just to let us know if that goes to 10 mils, to let us know that we can prepare more medication just in case the machine hasn't programmed the volume, so that doesn't alarm and say volume infused and turn off. Just for safety reasons, turn that down and just tell staff how many mils are left in the syringe, so that we can be vigilant, especially if we're supervising between 3 or 4 patients, that we can be vigilant that the medication won't run out at any time. So I'll just show you to change the medication. We'll be opening this wing here. Perform change, yes. So that opens up. So there's little butterfly wings here, and they have to fit in there, in between the arms, in between this little green there. So you have to try to get it in between there. And it's nearly better to hold it in place and try to turn this at the same time, because as you can see it sits in between. If I don't put it in place properly, it will say syringe loaded incorrectly. So there is a safety feature on that, just to show you when it's incorrectly. So I was saying just try hold it in between there and turn it at the same time, which it is a little tricky to do. And it'll load that syringe properly then as well. So we'll have that's NORAD DS double strength. So I'll have my dose. My dose is 10 mics a minute. My concentration is 6,000 mics and 50 mils. My rate will be 5 mils an hour. So the volume isn't written in here, so therefore my machine isn't going to alarm because it hasn't been told how much volume is there. So for example, this is saying this 55 and it would only be 50 max, but I'm just going to put down 40. So that will give me time, that just in case we're busy and no one has had a chance to look, this will alarm when it goes to 40 mils. So I'm giving myself 15 mils there, just for safety, so that we can inform senior staff just to know when they do need to start double pumping their noradrenaline and when the infusion is about to run out, just so we're aware of that. I'll just say for demonstration purposes that this is propofol. So I'm just saying for the infusions of sedation, just for staff to be aware, to let us know if any medication does look like it's running out, just so we can be aware and we can try prepare that to be on top of the medication at all time. So yeah, there your arterial line, there are the infusions there, just using this for demonstration purposes and just pretending it's a central line.